Thank you, Jill. I have to confess, I'm not an experienced researcher in HIV and AIDS because I dealt with more on NCDs. So, but many of the things I'm going to talk about, I think, bear relevance to HIV best practice as well. So what I'm going to address is we have so many clinical practice guidelines, including those in HIV and AIDS. In China, the average number of clinical practice guidelines has been rising rapidly over the recent decade. Yearly, we have almost about 1,020 clinical practice guideline or consensus coming out. But to what extent those clinical practice guidelines has been adhered to by the clinicians? There is a very famous quote. Globally, it takes up to 17 years to only implement 14% of the evidence. Our group also do a study using unannounced standardized patient. Those are the fake patient. We send them to visit a random sample in China in primary health care, so we can have a very good, accurate understanding of to what extent the clinicians are implementing the guideline recommendations. Our interim results has found out they generally adhere to only less than 20% of the guideline recommendations. So if the guideline, we have so many guidelines, spending so much money on producing them, but very few people actually pay attention to them. What is the purpose of producing those guidelines? So I would call that the bubble of guidelines. That is where the implementation science is coming. There are many different definitions on implementation science, but for me, the core is clear. The core of implementation science is really to get something we call evidence-based practice, EBP. Those are the practice which are already backed up by evidence. So the goal of implementation science is to get those EBP to be adopted, implemented, and sustained in true daily routine of the practice. So implementation science deals with understanding the barriers and facilitators to the implementation, and also to develop and evaluate the implementation strategies which can promote the adoption of those EBP. So specifically to clinical practice guideline, what might be the barriers to its implementation? There is a systematic review of the reviews. It suggests there are broadly 4 types of barriers. The first type of barrier is related to the guideline themselves. The other 3 are related to clinicians, to patients, and to other contextual factors. I would like to broadly divide those into 2 groups of barriers. One are those intrinsic to the guideline themselves. Those are the barriers which the guideline developer can actually address in the development of guideline. The other are, I would call broadly, the contextual factors. For the contextual factors, one is related to clinicians. For instance, clinicians may simply are not aware or not supporting the recommendations. Or clinicians, when their practice experiences increase, studies suggest they tend to ignore guideline more. There are also characteristics related to patients. For instance, most of the guidelines targeting single conditions. But in the aging society, we have more and more patients who come in with multiple comorbidity. So when in those cases, how the recommendations for single conditions can be actually applied for people with comorbidity. That is a challenge. There are many other contextual factors. For instance, one of the common ones is simply the lack of time, human resources, and other resources to implement a guideline. There is also lack of support from the peers, from the supervisors, and there is also very common, there is a high pressure for the clinicians, so people do not want to change. They want to stay in the comfort zone. But more characteristics related to determinants of guidelines implementation are related to guidelines themselves. one of the key, most important challenge intrinsic to the guideline is guideline is simply too complex, very difficult to be understood, lack of trialability, and sometimes require special resource to be implemented. This is very common in China. For instance, a guideline may say, you need to do this and that in the primary health care setting, but the primary care doctors do not have the certain resources, diagnostic tests, etc., to implement it. So how can we deal with the guideline implementation? Because we divide those barriers into two groups. One group is intrinsic to the guideline themselves. To that, in implementation science, what we can do is to optimize the clinical practice guideline, to optimize the content, language, evidence base, so that the guideline themselves can improve implementability. The other type related to contextual barriers, which can be dealt with something we call implementation strategy. Implementation strategy is also intervention, but the purpose of implementation strategy is no longer directly to improve health outcome. Their purpose is to improve the adoption and the implementation of the EBP, in this case, the clinical practice guideline, then using that as an intermediate to achieve health outcomes. So those implementation strategies with the purpose of implementing and achieving implementation outcomes. Generally, in general health service research, we care more about patient outcome and service outcomes. But in implementation science, we care more about implementation outcomes, which related to acceptability, feasibility, adoption, cost, fidelity, penetration, and sustainability. Very often we use fidelity as a primary outcome for implementation research. Fidelity is the extent the given protocol is implemented as per protocol. But that is not to say we will not change anything in implementation, but it is saying to what extent you are keeping to the fidelity and to what extent you are doing systematic adaptation according to context. So in the following, I'm going to give several examples. Our team, a KCI lab for implementation science, is conducting in regard to either optimizing the guidelines themselves or coming up with implementation strategies to deal with this issue. First is optimization of guidelines. My PhD student, Dong Mei Zhong, is doing the systematic work in that regard. So what she is doing is first to understand what are the existing theory, models, and framework in dealing with implementability of guidelines. Then he will consolidate all of the existing conceptual frameworks into one consolidated framework for guideline implementability. There are currently 5 or 6 implementability-related frameworks, but none of them are sort of the scale, so they are framework. So based on those frameworks, consolidated one, we will also develop an implementability measurement scale, so we can quantify to what extent the existing guidelines are actually implying their implementability according to the domains and the constructs of the framework. After we have validated this scale, next thing we are going to do is first to test out in China to measure all of the existing clinical practice guidelines to measure their implementability. After getting a very good sense of the implementability of each guideline, we are going to write up a summary of its implementability, then feedback this information to the guideline developers. So in the hope they are going to use our recommendations and feedback for improvement in the next round of revision. Here is a framework I think is quite comprehensive from Professor Gagnidia from Canada, but I will not go into details of this one. Here are the few other common existing frameworks. Again, we are going to consolidate those frameworks into one particular one. Now, what are the, think about if we have already optimized clinical practice guidelines, they still have many of the contextual barriers to be implemented, as I mentioned before. So to deal with this, we have to develop specific implementation strategy and also evaluate the effectiveness of those implementation strategy. Implementation strategy is also an intervention. The common implementation strategy in China for guideline adoption is very simple. Training, education, monitoring, facilitation, those are the very common strategies. There is already a very nice framework called APACC. APACC is an implementation strategy framework which provides taxonomy to implementation strategies. It broadly classifies implementation strategies into 9 categories. So if you are interested, there is a website for APACC, and they give you very detailed information on underneath which category, what are the available implementation strategy which have already been tried out in the prior literature. So normally, what we do in the typical implementation study, in our group, we develop a model called PETALS. In the PETALS model, you start with problems, then you identify an EBP which can help address the problem in the clinical practice. Then you're looking at the barriers and the facilitators using the implementation science frameworks. Then you match your implementation strategy to deal with the specific barriers. So there is a matching process of matching the implementation strategy to the particular barrier. Then you test the effectiveness of the implementation strategy in accordance with the implementation outcomes you have outlined. So what are the particular type of implementation studies we can do around the implementation strategies? So we do 3 types. The first type is a typical using PETALS model, the typical study of, I would call that the complete implementation study from the beginning to the end, following the problems, identify EBP, identify barriers, identify implementation strategy matched to the barriers, then coming up with the research design and the method and the implementation outcome, then test the effectiveness of the implementation strategy in promoting the adoption, implementation, and the sustaining of the EBP. So that is a very complete set. In our group, Professor Jiang Yun is doing a study trying to come up with the implementation strategy to promote the adoption and use of something called a brief language intervention to promote tobacco cessation among primary care providers. However, in our study, we don't need to necessarily go through this entire process for implementation studies. So the second major category our group is doing is to actually look at the existing implementation strategy from the APACC framework. Because many of the implementation strategies included in the APACC framework lack certain empirical evidence to back it up. For instance, one of the very common implementation strategy is called audit and feedback. It's very simple. If you want to promote something among clinicians, you audit, you understand to what extent they are actually doing the work. Then you provide them with constructive feedback. They already have over 100 RCTs to test the effectiveness of that. However, studies suggest this. The new knowledge actually stops after the initial 30% of the RCTs. Why? Because everything is wrapped under the broad name audit and feedback. But for audit, for feedback, there are so many ways of doing that. This is very common, in my view, in health services study. We do something, we call it the same name. It's simply like paid forward, the same thing. We do paid forward, but we have different ways of doing paid forward. We have many components within paid forward. But what components are actually effective within that package? Which components, when combined together, can be the most powerful combination of your packaged intervention? That is the question. So our study in this way is actually take out those common implementation strategies, but trying to understand the individual component within it, and to search for the most powerful combination of the components when in what way they can be packaged together can serve the purpose of promoting implementation. So several of our studies of doing that. The second one we are doing that is we're using different kind of incentives in clinical setting to promote clinician adherence to clinical practice guidelines. Very common one are the financial incentives. But there are many other non-financial incentives. But in the past, we always compare using incentives and not using it. But what the managers are interested in is what are the relative benefits of one intervention versus the other incentive intervention. So our group is doing is really to compare the financial intervention versus the non-financial intervention. The third group, using my last 3 minutes, is what are the other innovative implementation strategies which are not included in the literature. Those are truly innovative. I would say pay it forward can be also termed as an implementation strategy because it is a strategy to promote the uptake of vaccination, which is EBP. You do not need to do studies around vaccination. What you need to do is coming up with implementation strategy that promote the adoption, sustaining, and the use of vaccination. But for our group, we are also doing those vaccination-related studies. So again, we are borrowing ideas from other areas. So we are trying to say whether or not the clinician in the vaccination center using one sentence brief verbal statement can improve the vaccination of influenza. So when people are coming to vaccination in the vaccination center for other diseases, the clinicians, the nurses will simply say one 10-second word. You can also do vaccination for influenza either today or we can schedule for you. So we are testing using a randomized control study whether this one sentence can improve the influenza uptake. So those are the different things. So one last thing our group is doing is also something called the pseudo set. Pseudo set is a very interesting idea used in the business world. In the internet, they have tested out ask people to donate clothing. If we have the world universe map, if you donate one piece of clothing, you light one region of the world. If you donate 5, the entire Earth is lighted. So they are testing out whether people have a sense of completeness. Then they find out using this very simple strategy, it's substantially increased the number of donations. So in our work, we are using standardized virtual patient on smartphone as a training mechanism for people in pediatric studying. So we are using something called, if you complete one case of study, you light one organ of your body. If you do all the 10 studies, the entire figure of person is lighted, is highlighted. So we are very simple strategy. We'll see whether that can actually increase in uptake of training in something. So in summary, this is a PEDOS model. I have a barcode over there, but unfortunately the presentation is in Chinese and the internet available. But here is the key messages. There is a bubble of a guideline. Implementation science is there to help. And for the barriers of a clinical practice guideline, there are something intrinsic to the guideline themselves. There are also contextual barriers. You need different strategy to deal with them. For guideline intrinsic barrier, we need to optimize guideline. For the contextual barriers, we need to develop implementation strategy to address with that. But also, for our team, we are a great fan of simple solutions. We like simple things rather than complicated things because sometimes the complicated things need very big change, policy change, health system change. Those are very difficult to do. So we need to search for what are something called radical incrementalism. The small step. You gather those small steps, small change together, so in the end, they can form the radical change for the clinical practice. We have the first conference on implementation science to be held in China in this October. So if you are interested, just email me. My email address is there, and we are ready to welcome you in Guangzhou in October. Thank you so much.